Good morning, guys. I was asked to do a video on HCG. The importance, relevance, understanding of HCG. I have done 2 blogs, but clearly nobody wants to read anymore. So here we go. Saturday morning before clinic. So let's do a quickie. To understand the importance of HCG, you have to have an understanding of the hypopituitary gonadal axis. Put very simply, testosterone, exogenous testosterone, suppresses the pituitary, and you do not release luteinizing hormone and follicle stimulating hormone from the pituitary down to the testicles. So, of relevance here is luteinizing hormone. Luteinizing hormone is the big player. Follicle stimulating hormone is not so important. Obviously, it has a role and it has an important role, but it's not as important as luteinizing hormone. So, luteinizing hormone stimulates the Leydig cells to produce testosterone. We also know that it has a role in fertility, so semen production or sperm production in the testicles. So, traditionally, we thought LH purely testosterone, FSH purely sperm, but it's not that simple. And actually, we do know that LH is the big player here, and follicle stimulating hormone actually has a rather minor role. So, why do we use HCG? Well, because testosterone replacement therapy suppresses the pituitary, we do not have the signals being sent down to the testicles. So we know that HCG mimics luteinizing hormone. The one thing to note is when you have your blood tests on testosterone replacement therapy, whilst it mimics luteinizing hormone, it will not show up in a blood test. So we sometimes get that question, what's going on? My LH is still really low, and I'm on HCG. It's because it does not get picked up in the LH blood test. Does that matter? No. It would be nice. It would be nice to have a quantitative marker to show how effective your HCG protocol is. And there is progesterone, and you can actually measure HCG. It's a tumour marker. But there's not enough data really to make that data valid or significant. So it's quite non-scientific, really. We go on how you feel. We go on the size of the testes. So yeah, it's not a very scientific way of looking at things, but it's the best that we've got at the moment. So yeah, testicular size. Even with HCG, you will get a little bit of testicular shrinkage because you're not stimulating the Sertoli cells, because obviously the FSH is not being released. But people on testosterone-only protocols will have testicular shrinkage because you're not sending those signals down to the testicles. Is that a problem, having peanuts for testicles? It can be. It can be quite painful. So, yeah, one reason is to prevent pain. Another reason is to keep the old kahunas a reasonable size. And the obvious one is fertility. So we now have 16 pregnancies, 15 little nippers, and one on its way, 20 weeks. So wonderful news. What if I don't want to have children? Do I still need HCG? Yes, to be optimized. I suppose it depends on what your definition of optimized is, because if feeling great is being optimized, then you don't always need HCG. However, normally you do to feel great. So you will get a sense of well-being and increase in libido from having HCG in your protocol. Why is that? Because obviously we're thinking about LH, telling the testicle to produce testosterone, fertility, but why would you feel better with HCG/LH in your protocol rather than just testosterone monotherapy? Well, actually, it's because there are LH receptors in the brain. So you are not stimulating those when you're on testosterone-only protocols. So that can bring about that sense of well-being and libido, something to do with dopamine. So yeah, LH receptors in the brain. What else? Well, there's also upregulation of the other hormones down from pregnenolone. So cholesterol gets converted to pregnenolone, and that cascades down to aldosterone, cortisol, and testosterone. Pregnenolone's called the father hormone. It's a super important hormone, obviously. You can actually buy it across the counter. So, yeah, it's the father hormone for all your steroid hormones. So when people want to crash their cholesterols because they have this false misconception that, cholesterol is bad, it's inherently bad, they're also lowering their pregnenolone, which is subsequently have a knock-on effect on the cortisol, aldosterone, and testosterone. So, don't want to do that. So, we've had testicle size, fertility, LH receptors in the brain, and we've had pregnenolone. So up-regulation of the other hormones down from pregnenolone. So, in order to be truly optimized, you need HCG in your protocol, irrespective of whether you want to have children. I think it's negligent not to offer HCG alongside testosterone from the outset. The NHS and private providers do not feel the same way. But you don't have to have an in-depth understanding of biology to understand that actually it makes sense that you should replace those hormones. And we are iatrogenically, so we know that we are suppressing LH through giving exogenous testosterone. So it seems rather bizarre that you would not replace that in the field of endocrinology. And so-called experts believe that HCG has no place in testosterone replacement therapy. They believe it's stacking, which is something that bodybuilders do. And I think what that means is using multiple compounds. I don't know, I'm not a steroid head. So, I'll defer to the expert who is not an expert, because if he does not understand the importance of HCG and testosterone replacement therapy, he is not an expert. So we work with a lot of guys, GPs, actually endos. We've got a professor who supports our work, and it's hard to get HCG on the NHS for testosterone replacement therapy. You can get it for male infertility, but you can't get it for testosterone replacement therapy. Now, there's a peculiarity in that, because we know that testosterone suppresses the pituitary and subsequently causes azoospermia because it's not sending the signals down to the testicles. So we are deliberately doing that. So why are we not replacing the LH with HCG that we know is effective? I think that is dodgy. I think that's really dodgy ground, because a male infertility clinic, you will get HCG monotherapy. But the NHS is treating you for testosterone replacement therapy, deliberately, knowingly suppressing your pituitary. It has a treatment to prevent you from becoming infertile, but it won't give it to you. If you want to become fertile and conceive, and you're on testosterone replacement therapy, the NHS will tell you to stop TRT. Kill me now. Okay, I do not understand the logic in that. It's absurd. So, I don't know, give me strength. So, HCG. What else do you want to know about HCG? how to prescribe it? Well, you prescribe it according to the needs of the patient. What are the needs of the patient? Well, we have a starting protocol that we use for most guys, and I would say the guys that struggle a little bit to conceive on that starting protocol, what we do is we titrate up the HCG dose and titrate down the testosterone dose, to hopefully obviously stimulate the testicles to produce testosterone and sperm. So yeah, I'm a big fan of daily injections to naturally resemble or mimic your physiological state. Can you perfectly mimic natural physiology? Oh, it's a shame, but no. Why? Why is that? Well, LH is released in a pulsatile manner from the pituitary, so it's not sending a constant supply of LH down to the testicles. In using HCG, obviously we're saturating the testicles with HCG/LH, so it's a constant flow of HCG, which is stimulating the testicles. Now, is that a problem? Not normally, because obviously what we're trying to do is reduce the dose that would be stimulated from the pituitary to a lower dose, so that the actual consistent dose, or the weekly dose or daily dose, would be the same. So it is a titration process, and it is a difficult titration because we don't have the quantitative markers. We go on sort of rather vague things like testicular size, and sense of well-being, etc. So it is a little bit vague, but 100 IU daily is my minimum dose that I prescribe. I do not believe it to be effective at a lower dose, and certainly from a testicular size perspective, that seems to be a dose that maintains a reasonable testicular size. So we do go up to sort of higher doses, sort of something on 350 every other day. We used to prescribe it 500 every 3.5 days, but that's pretty much old school. You know, we've moved over to this micro dosing because it's the most effective way of establishing stable levels, and we're trying to avoid peaks and troughs, obviously. I repeat this ad nauseum. So peaks and troughs tend to cause estrogen spikes, as well as people not feeling well, because you know the body is constantly trying to maintain the state of homeostasis, and if you're administering an exogenous drug such as testosterone, such as HCG, such as anything, you know, your body has to react. So we go by the idea of small frequent doses to minimize those peaks and troughs, and it's clearly effective. So yeah, the estrogen discussion. I can't get on with HCG because it spikes my estrogen. Yeah, it's likely partly because of the fact that the stimulation of the testicles is slightly abnormal, but it's also likely it's because you're a bit of a chunky monkey. So unfortunately, you have an increased rate of aromatization if you are chunky. Lydia's nickname for me. 13% body fat, I'll have you know. Also, liver dysfunction. If you have mild liver dysfunction, and that won't show up in a blood test, unfortunately. I'm sure we all have an element of mild liver dysfunction because we're exposing ourselves to chemicals that we're not supposed to be exposing ourselves to. All that BPA crap and all the poisons. So I'm sure we have an element of mild liver dysfunction, irrespective of having a clean diet or whatever, because it's just nigh on impossible to be that healthy. So yeah, that increases the expression of production of the aromatase enzyme. Booze, what a shame. booze. How dare you, you evil, evil, evil substance. Yeah, that causes the overexpression of the aromatase enzyme. So you'll have an increase in estrogen. So, not getting on with HCG because of estrogen. Well, I would far prefer you to be on HCG and control your estrogen. Now, we've always tried to have a very puritanical viewpoint on health, on everything. So less is more. However, less when it comes to hormones from the perspective testosterone monotherapy causing subsequent suppression of LH. Well, that doesn't make sense to me. You know, you should replace all of your hormones. So you're deficient in testosterone, replace the testosterone. The testosterone causes a subsequent decrease in LH, replace the LH. It's not rocket science. Well, it shouldn't be rocket science, but apparently it is. And it's seen as radical and maverick. And it's like, well, I'll tell you what, 16 pregnancies. There you go. There's your answer. We've got over 400 guys. Some of them are working towards optimization, but a lot of them are incredibly happy. A lot of them have come across from the NHS on their testosterone monotherapy. Lots have come away from providers for numerous reasons. But one of those is obviously HCG. You know, I'm sure the reason why they don't advocate HCG is simply because they can't make enough of a markup on it. So you have to remember, do your research. You know, the information's out there. It doesn't take much looking for to have a look at this HPG axis and understand, testosterone, okay, suppresses it, so yeah, okay, replace LH, yeah. All hormones are there for a reason, okay? We need to appreciate that, and I think, you know, it's not rocket science. So we've evolved over millions of years, and we have an arrogance about us to say, well, I don't need HCG, I feel cracking. It's the same, the idiots who are on this testosterone cream saying about there are no long-term harmful effects from having high DHT. Yeah, when the data's 2 years old, or the data's 2 years, that's not long-term data. And we know that all hormones should be in balance. Now, you might feel great with high DHT, but we know that everything has to be in balance. The body fights so hard to maintain this state of homeostasis, and we have an arrogance and think we know better. We don't know better than Mother Nature. You know, there's an absurdity to, it's embarrassing, quite frankly. So, HCG. What else do we know about HCG? There's lots of procedural things. I'll put a link to the blogs, so if you are a reader, what you reading for? Bill Hicks. You know, have a read. Videos are good. Well, hopefully they're good. But I mean, it's you don't retain the information as well as you do when you read. So I will put links to the blogs. But YouTube's great for opinions, and hopefully you'll have an increased understanding from having a quick listen to this. So, God, 19 minutes, been banging on for 19 minutes. Right, I'm going to go and do some work. No rest for the wicked.